So let us start the another theory class number 18, and in this class we are going to discuss about the systemic pharmacology. Under the systemic pharmacology, first I am going to discuss about the digestive system pharmacology, and in this digestive system pharmacology I am going to start with the drug used for the therapy of gastric acidity. So pharmacotherapy of gastric acidity, or drug we have to use for the therapy of the condition that we call GERD, gastroesophageal reflux disease, or the drug that used to treat the ulcer, particularly the peptic ulcer, and also a condition in which the amount of acid secrete are very high, and the name of the syndrome is Zollinger-Ellison syndrome. So let us start about the drug used to treat the acidity or the peptic ulcer or the GERD or Zollinger-Ellison syndrome. So let us start with the first. What is the pathophysiology of ulcer? How the physiological phenomenon occur to produce the ulcer? So there are infection, particularly a bacterial infection, and the name of bacteria is Helicobacter pylori. So Helicobacter pylori is participating in the formation of peptic ulcer. And other conditions which lead to the peptic ulcer are when there is imbalance between the mucus, and condition which damage the mucus, and protective agent. So if there is imbalance occur between the mucus damaging and protective agent, then this may resulted into the peptic ulcer. How? If the amount of the mucus is less and the HCl hydrochloric acid is secrete more, if the enzyme pepsin is more, then because of the lack of mucus, it will damage the mucosa of the gastrointestinal tract. Or even if the protective agent is less in amount, then the acid is going to digest the mucosa, gastric gastrointestinal mucosa, and therefore it may lead to the peptic ulcer. So protective agents which check or participating in the formation of peptic ulcer, they are also called cytoprotectant, are mucus and bicarbonate. As we know, the mucus is going to coat the mucosa, and therefore HCl will not penetrate easily the mucus to reach the layer of the gastrointestinal layer, and therefore it check to reach there and prevent the autodigestion. And as we know, the compound bicarbonate is going to dilute the action of hydrochloric acid, because it is alkali, so it is diluting the effect of acid, and by these all means they are going to check the formation of peptic ulcer. So similarly, we are going through the same way of the etiology or the cause of ulcer, and we are going to check these to inhibit the formation of ulcer. Like if there is infection, which form the peptic ulcer. So we are going to kill the bacteria or inhibit the infection by using the drug. If there is more acid production, so we are going to use the drug which inhibit the acid secretion. If there is less protective agent are there, so we are going to use the drug which enhances the cytoprotectant like mucus and bicarbonate. So by these all means we are going to treat the peptic ulcer or acidity. What are the condition? What are the cause which produce the condition like acidity, the condition like GERD or Zollinger-Ellison syndrome or peptic ulcer? These may be because of the stress, maybe the genetic factor, maybe because of the smoking, maybe the because of the taking of drug, non-steroidal anti-inflammatory drug, maybe because of the consumption of alcohol. So these all are the factors which participating in the formation of the peptic ulcer or acidity. And once the patient is going through the peptic ulcer disease or the acidity, the patient is going to feel the symptoms, sign and symptom like if there is more acid, then it may produce the ulcer and therefore you may find the blood in the vomission. When there is more acid, then this is going to produce the abdominal discomfort. So abdominal pain is there. If there is more acid, then there or the peptic ulcer, then this is going to produce the nausea. Also, this is going to produce loss of appetite. So when there is nausea, loss of appetite will occur. Automatically, it resulted in the weight loss. And when there is more acid, it may produce the condition like the heartburn. So these all sign and symptoms which is indicating that patient is suffering from either acidity or peptic ulcer, and therefore accordingly we have to treat the patient. So now we have to go through the physiology of the acid secretion. So we are going to discuss about the physiological and pharmacological regulation of gastric acid secretion. So if we aware about the physiology of gastric acid secretion, then automatically we are going to target the pathway to inhibit the gastric acid secretion. So, as we know, there are many or various types of cells which participating in the gastric acid production as well as the gastric acid inhibition. So, we have to see how the gastric acid is going to be secreted and what are the cells that participating in the gastric acid secretion. So as we know, within the stomach, there are various cells like parietal cell, like mucus cell, that is also sometimes called superficial epithelial cell, then the enterochromaffin-like cell, then the G cell, then the D cell. So these cell and also enteric nervous system and accumulation of these all cells and as well as the enteric nervous system are participating in the gastric acid secretion or gastric acid inhibition, and let us see how the gastric acid is gets secreted. So as we know, a hormone called gastrin is released by the cell found in the stomach, and we call it the cell of is called G cell, and the G cell is going to release a hormone called gastrin, and this gastrin is going to participate in the production of HCl directly and indirectly. So this gastrin hormone released by the G cell acting on the receptor present on the enterochromaffin like cell and therefore indirectly participating in the acid production. So gastrin is going to attach with the receptor called CCK2. So this CCK2 present on enterochromaffin like cell, and therefore gastrin activate the receptor, and therefore histamine get released, and that release histamine within the lumen of the GI tract, particularly in the stomach, is now acting on the main cell which is participating in gastric acid secretion, called parietal cell. So histamine is acting on the histamine receptor. We call it the H2 or histamine type 2 receptor, and therefore it get activated, and through cyclic AMP dependent pathway, it further activates the enzyme, and the name of enzyme is hydrogen ion, potassium ion, ATPase enzyme, or also called proton pump. So histamine activate the receptor H2 receptor, and therefore there is activation. Because of activation of this receptor, cyclic AMP get formed, and this cyclic AMP is going to activate the enzyme hydrogen ion potassium ion ATPase, and the name is clear cut indicating because of the activation of this proton pump or this enzyme, it will help to efflux out the hydrogen ion within the lumen. So when within the lumen, hydrogen ion get released within the lumen of stomach, going to combine with the chloride that also released within the lumen, and both combine to go to form the hydrochloric acid. So this is the indirect pathway of gastric acid secretion by the hormone gastrin. Another pathway, gastrin, is, so here simultaneously I am going to tell about the drug also. So if the drug which inhibit the receptor, which antagonize the receptor H2 receptor, and inhibit the binding of histamine on the H2 receptor, that we will act or we will use the drug as a H2 receptor antagonist, and therefore hydrogen ion will be not released in the lumen of a stomach, and therefore it will uh, reduce the hydrochloric acid production. How? This gastrin stimulated the histamine release, and therefore histamine is not able to bind with its receptor H2 receptor, because the receptor is occupied by the drug, and we call that drug H2 receptor antagonist, or, and therefore cyclic MP by the parietal cell will be not formed, and therefore activation of enzyme will not occur, and therefore hydrogen ion will not release, and therefore finally hydrochloric acid will not form. So therefore this is the one pathway, that is the indirect pathway of release gastric acid released by the gastrin. Same hormone is also acting directly on the parietal cell to release the hydrochloric acid. So gastrin is going to act on the receptor CCK2 present on the parietal cell, and then it get activated. Because the activation of CCK2 receptor of the gastrin, cyclic calcium ion get released intracellularly. So once calcium ion get increase intracellularly, and we call it calcium dependent pathway, and because of the raised amount of calcium within the parietal cell, activate the enzyme hydrogen ion potassium ion ATPase, and therefore the same way of release of hydrochloric acid occur. But here the pathway is calcium dependent pathway. So gastrin directly acting on the receptor called CCK2. It activate. Thereafter, intracellular calcium level get raised, and therefore raised intracellular calcium level activate the enzyme hydrogen ion potassium ion ATPase, and therefore hydrochloric acid finally released in the lumen of the stomach. So if this is about the another pathway of gastrin that will helps to release the gastric acid by the parietal cell. So if any drug which directly inhibit the enzyme hydrogen ion potassium ion ATPase or proton pump, and because of inactivation of this enzyme there will be not hydrogen ion released, and therefore a hydrochloric acid will be not formed within the lumen of a stomach. And the drug that inhibit the function of this enzyme hydrogen ion potassium ion ATPase or proton pump are called proton pump inhibitor, and the drug will be used as a antacid or used for the therapy of peptic ulcer. So this is the another pathway. Now we have to go through the neurotransmitter acetylcholine. So when acetylcholine is released by enteric nervous system, therefore, this neurotransmitter acetylcholine is going to act on the muscarinic receptor present on parietal cell. So when the acetylcholine released by the enteric nervous system is acting on the muscarinic type 3 receptor present on the parietal cell, and it activate the receptor, and after the activation of muscarinic receptor the intracellular calcium level get raised, and raised intracellular calcium level, that is also called calcium dependent pathway, activate the again enzyme hydrogen ion potassium ion ATPase, and finally hydrogen ion get efflux out and finally helps to form the hydrochloric acid. So if any drug which bind to this receptor and inhibit the binding of acetylcholine to its receptor is used as a drug for the antacid, drug for the therapy of acidity, or drug used for the therapy of peptic ulcer. So this is the another pathway. Now we have to go through more pathway. The autoquad like prostaglandin E2 and prostaglandin I2 have the physiological function in inhibiting the release of hydrochloric acid. How? So prostaglandin E2 and prostaglandin I2 autoquad acting on its receptor present on both parietal cell as well as the mucous cell or superficial epithelial cell. The receptor is EP3. So the receptor get activated, ep3 receptor get activated in parietal cell, and because of the activation of the ep3 receptor by the prostaglandin E2 and I2, it have the negative effect, or it will inhibit the formation of cyclic AMP. So therefore the low level of cyclic AMP not activation of enzyme will occur, and therefore hydrogen ion will be not efflux out to participate in formation of hydrochloric acid. So prostaglandin E2 on parietal cell inhibit the gastric acid formation, and when the same autoquads are acting on the ep3 receptor present on mucous cell or superficial epithelial cell, it have positive effect after its activation in release of cytoprotectant mucus and another cytoprotectant bicarbonate. So how this mucus is going to help in the inhibition of formation of peptic ulcer? This release mucus is going to cover the mucosa layer of the gastrointestinal tract, and therefore acid will not help to digest the layer of the gastrointestinal tract, as well as it also inhibit the digestion by the enzyme pepsin. So that is why this is called cytoprotectant. Another thing, bicarbonate get formed. This bicarbonate, as we know, this is alkali in nature, and therefore it is increasing the pH by diluting the HCl, and therefore this nullifying the effect of hydrochloric acid over the gastroepithelium or the mucosa of the gastrointestinal tract. So therefore they are called mucus and bicarbonate are cytoprotectant, and their synthesis get increased by participation of autoacquired PGI2 and PGE2, and the drug which potentiate or which is analog to prostaglandin may helpful or may be used for the therapy of peptic ulcer or gastric acidity. So as we know, the non-steroidal anti-inflammatory drug, as we know that non-steroidal anti-inflammatory drug is inhibiting the synthesis of autoacquired prostaglandin E2 and prostaglandin I2. And therefore, because of the inhibition of the E2 I2 prostaglandin by non-steroidal anti-inflammatory drug, by inhibiting the enzyme cyclooxygenase, the prostaglandin will be not formed, and in long-term therapy of non-steroidal anti-inflammatory drug, it will produce the ulcer condition, or this is going to helps to produce the disease condition like ulcer formation. So long-term therapy of non-steroidal anti-inflammatory drug is rather contraindicated, because this is going to produce the peptic ulcer. So we are going to use the drug misoprostol, that is the prostaglandin analog, and this is going to potentiate the effect on the EP3 receptor present on the parietal cell as well as present on the epithelial cell, and helps to decrease the acid secretion as well as helps to increase the cytoprotectant mucus as well as the bicarbonate. And as we know, the infection of Helicobacter pylori is also participating in the formation of the peptic ulcer. So we have to use the drug which kill the bacteria Helicobacter pylori, and the drug like bismuth, metronidazole, tetracycline, clarithromycin, amoxicillin are to be used for the to kill the, or these are the antimicrobial to kill the Helicobacter pylori, and therefore it inhibit the formation of peptic ulcer. So we have seen what is the physiology of the gastric acid secretion and what are the pathway which we have to block, by which the gastric acid will be synthesis will be decreased, or the cytoprotectant amount will be enhanced like mucus and bicarbonate, and inhibit the acidity as well as the peptic ulcer formation. So therefore we are going to use these drug for the therapy of gastric acidity, peptic ulcer, GERD, Zollinger Ellison disease. Now here is interesting one more hormone we call the somatostatin. Somatostatin is the hormone which is produced by the cell, and we call it the D cell. So D cell release a hormone. We are calling it the somatostatin. So somatostatin is acting on the G cell to inhibit the release of gastrin. This is one important function. This somatostatin is also present its receptor on parietal cell and therefore this is also participating in inhibition of acid. So somatostatin is inhibiting the gastric acid production by inhibiting the release of gastrin hormone from the G cell, and also acting on the receptor present on the parietal cell to and inhibit the synthesis of hydrochloric acid. So this is about the somatostatin function. So acting on the gastric cell, and also it is also acting on the enterochromophil like cell to inhibit, and therefore it inhibit the release of histamine. So this is about the gastrin, about the acetylcholine, about the somatostatin, about the prostaglandin E2, I2, and about the histamine. So we already discussed about these things. Now, so this is about the physiological function of gastric acid release from the parietal cell. Now we have to go through the now we have to go through the classification of the drug that are to be used for the therapy of peptic ulcer or GERD or gastric acidity. So now we have to classify the drug, and these drugs are to be used for the therapy of the condition like gastric acidity, then the condition of GERD, then therapy of peptic ulcer, then the disease acidity condition like Zollinger-Ellison syndrome. So now we have to go through the classification of the drug. So the first drug that we are going to discuss under the classification are called antacid. So antacid is name is indicating against the acid. So here we are going to discuss only about the chemical which neutralizes the acid that already released in the stomach and present in the stomach. So we have to chemically neutralize the HCl present in the stomach after its release. So this is also called chemical neutralization of hydrochloric acid, or also called antacid. So in this we are going to use the chemical, and these chemical neutralizing the acid, that means the chemical we are using are base in nature. So they are basic in nature. So for this chemical neutralization, we are using the chemical that act non-systemically, or some of the agent get absorbed systemically, so they are called systemic antacid, and another one that is not absorbed or less absorbed is called non-systemic antacid. So under the systemic antacid, the best example is soda bicarbonate, or another one example is sodium citrate, and non-systemic antacid are the mixture of compound, or singly also the compound are magnesium hydroxide, aluminum hydroxide, or mixture of both. So mixture of both magnesium hydroxide and aluminum hydroxide is best choice, and their mixture is also called megaldrate. MAG, so it stand for magnesium, AL stand for aluminum, and drate means hydrate. So magnesium hydroxide as well as the aluminum hydroxide is in combination, a compound is called megaldrate, is hydroxy magnesium aluminate complex, and that is used as a non-systemic antacid. And how they drug these are acting? They are going to chemically neutralize the hydrochloric acid by combining with the hydrochloric acid, I mean the HCl, and therefore form the water and salt. They form the water and salt to neutralize the acid. So this is the mechanism of action of the chemical neutralization, or called the antacid. Now we have to go through the drug that we that the drug is mainly inhibiting the synthesis or release of hydrochloric acid by the parietal cell, or you can say some of the drug by the parietal cell, mainly by the parietal cell. So now we have to go through the drug which inhibit the gastric acid secretion by the parietal cell. In this, the best example, the drug that are mostly used are called PPIs. PPIs means proton pump inhibitor. So because this is inhibiting the enzyme hydrogen ion potassium ion ATPase, so they are also called hydrogen ion potassium ion ATPase inhibitor. And because the enzyme is also called proton pump, so this is also called proton pump inhibitor. So in this all the drug they possess the suffix prazole. So the drug are omeprazole, lansoprazole, rabeprazole, pantoprazole. So their suffix is prazole, and they are going to inhibit the function of this proton pump or the enzyme. They are most potent, and they are also irreversibly bind with the enzyme and block its action, and they are also long acting. Omeprazole is the mixture of R and S isomer. So racemic mixture of R and S isomer. Its S isomer of omeprazole is called S-omeprazole. So this is about the proton pump inhibitor that we already seen. This is the proton pump. So the drug is going to act on this, and therefore it irreversibly bind and inactivate the enzyme, and therefore inhibit the release of hydrogen ion, and therefore hydrochloric acid will not be formed. Another one under the classification is H2 receptor blocker. So name is that we already discussed. H2 receptor blocker means the drug that occupy the H2 receptor. So drug are going to occupy the H2 receptor, and therefore histamine will not find the place to attach with the receptor. So therefore the histamine will not able to act through H2 receptor and produce cyclic MP, and therefore not enzyme or proton pump get activated to efflux out the hydrogen ion, and therefore no hydrochloric acid formation occur. So this is about the H2 receptor blocker or antagonist. It will bind with the receptor, so histamine is not able to bind with the receptor to produce the production of hydrochloric acid. So this is about the H2 receptor antagonist. Under the H2 receptor antagonist, they are usually have the suffix like tidine. Example are ranitidine, cimetidine, famotidine, nizatidine. They all are called H2 receptor antagonist or blocker because they are going to block the receptor. So that is why they are called blocker or antagonist. They are short duration in action. Then the PPI, proton pump inhibitor, and next under the same the drug that which inhibit the gastric acid secretion is muscarinic blocker or anticholinergic or antimuscarinic. So we already seen over the parietal cell the muscarinic type 3 receptor is present, and with that neurotransmitter acetylcholine is get attaching, and it releases the calcium ion intracellularly in high concentration, and therefore this high concentration of intracellular calcium activate the enzyme through the calcium dependent pathway to release the efflux out hydrogen ion to form the hydrochloric acid. So the drug which again similar to the H2 receptor antagonist, it bind with the muscarinic receptor, so therefore it is called muscarinic antagonist. So this is the receptor for parasympathetic nervous system, that is the muscarinic receptor, and therefore the because of the binding with this receptor the drug is going to bind with this receptor. So therefore acetylcholine is not able to produce its physiological function to participate in synthesis of hydrochloric acid. And this is not very much in use. The drug that which use as antimuscarinic, anticholinergic, that are not very much in use, and the drug are atropine, pyrangiapine, telangiapine, and dicyclomine. So these all are the muscarinic blocker. They are also called, the receptor is called cholinergic receptor. So this is known as anticholinergic or antimuscarinic. So this is about the inhibit the release of the acid from the parietal cell by blocking the action of acetylcholine on muscarinic receptor type 3. Now the another drug that is also going to inhibit the synthesis of hydrochloric acid through the parietal cell, we are going to use the prostaglandin. So prostaglandin analog, that is the misoprostol. Misoprostol is called prostaglandin E1 analog. So misoprostol is to be used. So how this misoprostol is going to inhibit the synthesis of hydrochloric acid? That, as we know, the prostaglandin E2 and I2 is acting on the EP3 receptor present on the parietal cell, and therefore through the cyclic dependent pathway inhibiting the efflux out of the hydrogen ion and inhibit the hydrochloric acid synthesis. And as well as this E2, I2 is acting on the EP3 receptor present on the epithelial cell, and therefore it helps to protect the mucosa by releasing the mucus and also diluting the acidity action of hydrochloric acid by the bicarbonate. So this way the misoprostol, that is the prostaglandin analog, is acting, and therefore this is all the drug that I have mentioned under the acid secretion inhibitor, that is the PPI inhibitor, that is the hydrogen receptor blocker, that is the muscarinic blocker, that is the prostaglandin analog. These all are going to inhibit the synthesis of the gastric acid from the parietal cell. So now we have to go through the other classific under the drug that are not particularly acting or primarily acting to inhibit the release of hydrochloric acid. Rather, it is going to protect the mucosa, gastrointestinal mucosa. So that is, therefore they are called mucosal protectant. They are protecting the mucosa of gastrointestinal tract. So therefore they are going to call the mucosal protectant. And they also seal the ulcer. So under this mucosal protectant or ulcer protective agent which coat the ulcer, they are usually basic in nature. The example are sucralfate and colloidal bismuth. This sucralfate and colloidal bismuth we have to discuss in detail. Now we have to under the same ulcer protective, the agents are CBS, colloidal bismuth subcitrate. So colloidal bismuth subcitrate is coating the ulcer, as well as this bismuth is killing the ulcer forming bacteria Helicobacter pylori. Not only that, this colloidal bismuth subcitrate is increasing the synthesis of prostaglandin E2. So the mechanism of action of CBS is through it kill the peptic ulcer forming bacteria Helicobacter. It also increase the synthesis of prostaglandin E2, therefore releases the mucus and bicarbonate. And it also going to coat the ulcer, cover the ulcer. Regarding the sucralfate is concerned, regarding the sucralfate is concerned, this sucralfate is going to form the gel with the mucus. So mucus is a protein. So the sucralfate is going to form the gel in acid environment, and this gel is going to coat the ulcer as well as mucosa and inhibit the further digestion of the mucosa by the hydrochloric acid as well as the pepsin and protecting it. So this is about the classification, and under the classification next and the last classifying drug, that is the antimicrobial agent. Antimicrobial agent means the drug which kill the peptic ulcer forming bacteria Helicobacter pylori. So the drug which kill the bacteria Helicobacter pylori are called antimicrobial agent, and these are amoxicillin, clarithromycin, tetracycline, metronidazole, and bismuth subsalicylate. So these all are going to kill the peptic ulcer forming bacteria called Helicobacter pylori. So this is all about the classification of the drug which used for the therapy of the peptic ulcer or acidity or the GERD or Zollinger-Ellison disease or syndrome. So now we have to go through the drug one by one that we have classified. The first one is the PPI. So under the PPI, we already we have to discuss about the mechanism of action of the PPI. That is the proton pump inhibitor. So when we are taking the drug, so most of the drug under this are prodrug. First important point, they all are prodrug. Second point is that they are irreversibly bind with the enzyme hydrogen ion potassium ion ATPase. So this is second important point. And we have to discuss now how this drug is acting, that is called the mechanism of action of the proton pump inhibitor. If you want to define this in simply way, so this, as the name is indicating, this is a proton pump inhibitor. So simple manner to define the mechanism of action is that the proton pump inhibitor like omeprazole, esomeprazole, lansoprazole, rabeprazole, they are going to bind with the enzyme and inactivate the enzyme. So therefore no efflux of hydrogen ion, and therefore there is no formation of hydrochloric acid occur. But if you want to go through the broad mechanism of action, then we have to go through that one. Usually the drug are prodrug first. They are also the prodrug, and the next point regarding this about the proton pump inhibitor is the prodrug and also irreversibly bind with the enzyme and also enteric coated. Why this is enteric coated? So when we are administering the drug through oral route, the proton pump inhibitor that we have mentioned, the prodrug are we are coating it acid resistant. Why? Because for its activation it required acid. So when we are not going to coat this, the drug itself get activating within the stomach and will not reach to bind with the target, that is the enzyme hydrogen ion potassium ion ATPase. So we have to check it, prevent it to get activated within the stomach by the hydrochloric acid already present in the stomach. So first the drug will have to get absorbed and reach in the canaliculi of the parietal cell. For that the drug are enteric coated. So enteric coated proton pump inhibitor come in the duodenum, and in the duodenum, that is the alkaline medium is there. So within the duodenum, the enteric coated drug, its coating get removed. So once its coating get removed, Now the drug is weak base get absorbed. So once the drug get absorbed after the decoating, it get transported. Where it get transported? In the cell from which the hydrochloric acid is participating in the formation of hydrochloric acid. So the name of the cell is the parietal cell. So the drug will get absorbed and get penetrated in the parietal cell canaliculi and it lodged there. So the drug get lodged in the parietal cell canaliculi. So this prodrug in the canaliculi, parietal cell canaliculi, get activated in acid environment because the acid is there. So this canaliculi prodrug get activated there, and once it get activated, this is going to combine with the enzyme hydrogen ion potassium ion ATPase with its cysteine moiety, cysteine residue. So after the activation of drug in parietal cell canaliculi, the drug active form get combined with the enzyme hydrogen ion potassium ion ATPase by its cysteine moiety, and the binding is very stable and the binding is covalent bonding, and thereafter after its binding it's inactivate the enzyme hydrogen ion potassium ion ATPase. So once the enzyme get inactivated, this will not participate in the efflux out of the hydrogen ion, and therefore hydrochloric acid will be not formed. Regarding its recommendation is concerned, this is recommended. I mean the all proton pump inhibitor are inhibiting the both basal acid production and stimulated gastric acid production, which is about more than 90% acid production is inhibited by the proton pump inhibitor. So the therapeutic use of the proton pump inhibitor that we already mentioned in the Jollinger-Ellison syndrome, also for the peptic ulcer healing, also for the GERD, and the PPI is also used along with the antimicrobial agent which kill the H. pylori, Helicobacter pylori. About the pharmacokinetic of the PPI is concerned, proton pump inhibitor is concerned, it is orally effective one. Some of the preparation is also intravenous is coming, that is the pantoprazole. So pantoprazole intravenous preparation is coming, and the route of excretion of the proton pump inhibitor is urine and feces. Regarding adverse effect of the proton pump inhibitor is concerned, the main side effect of the proton pump inhibitor is if you are using proton pump inhibitor for longer time interval, so acidity is less. So if the acidity is less in the gastric or in the stomach, so because of low acidity, it will inhibit the absorption of vitamin B12. So vitamin B12 absorption will be occur less when we have to use PPI for long-term therapy, because the acid environment is less in the stomach and low in stomach. Therefore, vitamin it impede the vitamin B12 absorption. So this is very, very important. So this is all about the PPI. Now we have to go through the another one, that is the H2 receptor blocker. Regarding H2 receptor blocker is concerned, the mechanism of action is concerned, that we already discussed. This is the reversible blocker, and this is the we also call competitive blocker. Reversible blocker means कि once the receptor get dislodged by the drug, the gastrin will or histamine will attach to the H2 receptor to produce its action. So which one is high concentration will be able to occupy the H2 receptor and produce the action accordingly. So if the receptor, H2 receptor, is occupied by the antagonist, H2 receptor antagonist or blocker, then histamine will not possessing the space to attach with the H2 receptor to participating in the hydrochloric acid production. So that is why they are called competitive blocker. And they are going to inhibit no doubt more than 90% of the basal acid production or food stimulated acid production, but mainly this drug are used for the acid production occur at night time. So this drug is very good for the therapy of inhibition of acid production in the nocturnal secretion of the acid, at night time acid secretion. No doubt this is going to be used for the therapy of peptic ulcer also, but it is to be less preferable than the PPI, proton pump inhibitor. So regarding the drug we already discussed, the cimetidine, ranitidine, famotidine, nijatidine. Here we are going to discuss more about the drug. Cimetidine was first in this H2 receptor antagonist. So they are called prototype of the drug. Cimetidine is the prototype of H2 receptor antagonist. Now we have to go through the therapeutic use of the H2 receptor that we already discussed. This is going to use for the therapy of peptic ulcer, then the GERD, and then the Zollinger Ellison disease, and also going to be used with the other antimicrobial drug which kill the bacteria participating in the formation of peptic ulcer, that is the Helicobacter pylori. Here very important point with this group of drug H2 receptor blocker is that they are OTC drug. OTC drugs are those drugs for the prescription is not required to purchase the drug. So this H2 receptor blocker are over the counter drug, and the prescription is not required for it has to be sell out. So this is very important. Regarding the pharmacokinetic property of this blocker is concerned, they are well absorbed orally throughout the body. And regarding the metabolism is concerned, about particularly cimetidine, about 30% of this cimetidine get metabolized through the first pass effect in the liver by cytochrome P450. So this is very important, and this is a hurdle to reduce its bioavailability. Whereas one drug in the same group, nijatidine first pass effect in the liver is very meager, very small, very less. Therefore, the bioavailability, oral bioavailability of nijatidine as compared to the other H2 receptor blocker are highest, which is about 100% because of the low first pass effect in the liver. Regarding its potency is concerned, ranitidine is about 5 to 10 fold potent than the cimetidine, whereas the famotidine is highly potent as compared to all other. So famotidine is about 20 to 50 times more potent than cimetidine, and famotidine is about 3 to 20 times more potent than the ranitidine. So amongst all the four, famotidine is highly potent drug. So this is very important. Now we have to go through the adverse effect of the H2 receptor blocker. The adverse effect, the side effect of the H2 receptor blocker are not much, and the side effect are headache, dizziness, diarrhea, and muscular pain. And one or two more side effect is that the drug, particularly the cimetidine, is anti-androgen. So because of the anti-androgen, that we know androgen is participating to give the male type of character in the male. So if this male is going to take cimetidine for long time interval, because of its anti-androgen activity, it will produce gynecomastia type of action in male, Also, this is going to produce galactorrhea. This is going to participate in milk production and also going to reduce the sperm count in case of male. So these are the side effects associated particularly with the cimetidine, that is the H2 receptor blocker. Other action of this cimetidine is it is also cytochrome P450 inhibitor, the enzyme which is participating in the metabolism. So cimetidine inhibit the metabolizing enzyme present in the liver, that is the cytochrome P450. So therefore what will happen if we are using cimetidine along with the other drug that is metabolized by the cytochrome P450, which the drug cimetidine inhibit. Therefore if we are using cimetidine along with the other drug like warfarin, diazepam, phenytoin, quinidine, carbamazepine, theophylline, imipramine, so their metabolism gets slowed down and therefore its potency get increased, because the rate of its metabolism gets slowed down when we are using these drugs together with cimetidine, because of the inhibition of metabolizing enzyme cytochrome P450, and therefore the drug unmetabolized form is remain within the circulation to produce activity, and this may be participate in the toxicity. Other thing is that this first pass effect of the ethanol is inhibited by the ranitidine, cimetidine, nizatidine. So ethanol first pass effect in the gastric mucosa is inhibited by the H2 receptor blocker like ranitidine, cimetidine, nizatidine. Another thing, one drug is ketoconazole. Ketoconazole require its absorption from GI tract, acid environment. So when we are using the drug that are H2 receptor blocker for longer time interval, particularly cimetidine, the acid environment is less, the pH is less because we are using the H2 receptor blocker, and ketoconazole required acid environment to absorb. So it get less absorbed when we are using the H2 receptor blocker for longer time interval. So this is all about the H2 receptor blocker. Now we have to go through the other drug, that prostaglandin analog. This is also inhibit the secretion of the acid from the parietal cell and also enhances the synthesis of mucus and bicarbonate from the mucus cell, that is the superficial epithelial cell. So the drug is misoprostol. So misoprostol is prostaglandin E1 analog, or you can say the prostaglandin analog, and used for the and the drug is called cytoprotectant, and also reducing the gastric acid secretion acting through the EP3 receptor present on the parietal cell, and increases the secretion of mucus and bicarbonate acting through the superficial epithelial cell. So they are called cytoprotective. Now this drug misoprostol is contraindicated in the pregnant animal. Why? Because misoprostol is also going to contract the uterus. So this may be contraindicated in the pregnancy, because when there is uterine contraction will occur in the pregnancy case, then there may be chances of abortion. So therefore the drug misoprostol is contraindicated. And now we have to go through the misoprostol is less effective than the H2 receptor antagonist and the proton pump inhibitor, and because of the less efficacy it is used not for the acute treatment of peptic ulcer. For acute peptic ulcer treatment we are not going to preferably use misoprostol. Drug like misoprostol, they are cytoprotectant, so we may have to use as a cytoprotectant. At higher dose of misoprostol is cytoprotective action, usually at higher dose, and also diminishing the gastric acid secretion that we already discussed. Now we have to go through the other pathway, that is the muscarinic blocker or anticholinergic or antimuscarinic, the drug like atropine, telangiecine, pyrangiepine, and also dicyclomine. So these all drugs are muscarinic receptor blocker, and therefore it block the muscarinic receptor M3 present on the parietal cell, and therefore what will happen, this is the mechanism, see here the figure, this is going to which this muscarinic receptor present on the parietal cell, the acetylcholine is going to be attached and produce the efflux of hydrogen ion and participating in hydrochloric acid formation through the calcium dependent pathway. So this receptor, muscarinic receptor, is blocked or occupied by muscarinic antagonist. So acetylcholine will not find to attach with their respective receptor to produce in the acid secretion. So this is about the muscarinic receptor blocker. But muscarinic receptor blocker is not in very much use because of its various action. So this is about the muscarinic blocker. Now we have to go through the chemical neutralizer. Or so this is all about that we all earlier discussed. This is all about the drug which helps to inhibit the gastric acid secretion by the parietal cell. Now we have to go through the chemical neutralizer. Means the hydrochloric acid that already released and found in the stomach, that has to be neutralized by the chemical. So chemically neutralization occur, that we already discussed. So how they act, they are basic in nature. They are usually weak basic in nature. They are going to react with the hydrochloric acid and they form the water and the salt and diminish the gastric acidity. So this is the mechanism of action of the chemical neutralizer, and because of that they raise the pH, and because it raised the pH, this the it any inactivate the action of pepsin, because pepsin require acidic or low pH to work. Now other than this chemical neutralization of the antacid or the chemical, they are also reduce the colonization of the bacteria. So this is helping to check the peptic ulcer, as well as it also stimulate the prostaglandin synthesis. So this is about the action of the chemical neutralizer. Now we have to go through the chemical. So we already discussed about the aluminum hydroxide, magnesium hydroxide. They both are used in combination mostly, but when we are going to use alone, they both are having some side effect. So therefore we are using it the in combination. Its combination is also called megaldrate, Mag magnesium, Al means aluminum, drate means hydrate. So magnesium hydroxide and ammonium hydroxide mixture is megaldrate, and magnesium hydroxide is also called milk of magnesia because of its color like milk. Now we are also going to use the calcium carbonate as a antacid, chemical neutralizer, because they are going to combine with the hydrochloric acid to form carbon dioxide and the calcium chloride. And the systemic antacid is the soda bicarb. Soda bicarb is a systemic antacid, but it has not to be used for longer time interval, because this is going to produce the alkalosis that we call transient metabolic alkalosis. So aluminum and magnesium hydroxide mixture we have to use to promote the healing of duodenal ulcer, and less preferable in acute gastric ulcer. So this is very, very important. Regarding the adverse effect of the chemical is concerned, as we told that when we are using ammonium hydroxide alone, this ammonium hydroxide is going to produce constipation, and when we are using magnesium hydroxide alone, this is going to produce the diarrhea. So therefore we are going to use together to nullify this side effect. The other side effect of aluminum is that they are going to combine with the phosphate and therefore produce hypophosphatemia. And because the sodium bicarb have the ion sodium ion, so therefore this is not very good for the patient like hypertension. And because of this sodium ion, this is for not to be used in hypertensive type of condition or congestive heart failure patient. This is also participating in the formation of carbon dioxide while neutralizing the hydrochloric acid. And this carbon dioxide, when released, it produces belching of flatulence. So therefore this is not very good. Now we have to go through the other drug that is coming under the mucosal protectants. So mucosal protectants is no name itself is telling this is going to protect the mucosa. So therefore they are going to call it the mucosal protectants. So mucosal protectant, the drug like sucralfate and colloidal bismuth that we already discussed earlier, but again we are going to discuss here. So they are mucosal protectant. So how they are mucosal protectant? We have to go through the drug. So sucralfate. So what is this sucralfate? Al indicating aluminum hydroxide. A sucra means sucrose and fate means sulfate. So sucralfate is the complex of aluminum hydroxide and sulfated sucrose is called sucralfate. So sucralfate is the mixture of aluminum hydroxide and sulfated sucrose. And regarding its mechanism of action is concerned, this sucralfate is in the acidic environment going to form the gel. With how they are going to form gel? This sucralfate is going to bind with the positive charge present on the protein. So where the protein is present, that is on the necrotic tissue or on the peptic ulcer, or the mucosa itself is a protein. So this sucralfate is going to combine with the positive charge of protein of mucosa or peptic ulcer, and therefore it form the gel like complex. And because you have formation of gel like complex, they are going to coat the gastro intestinal mucosa. So when this will coat the gastrointestinal mucosa, the digestion of mucosa get inhibited by the hydrochloric acid or the enzyme or like the pepsin, and it will protect the gastric mucosa. So therefore it is called the cytoprotectant. So this is the mechanism of action that I have mentioned. Other than that, sucralfate is also participating in it stimulate the prostaglandin release. So when the prostaglandin is released by stimulated by the sucralfate, the mucus and bicarbonate get increased, and these two are also cytoprotectant. Now sucralfate that I already discussed, sucralfate required acidic pH to get activated, and usually not active when the pH is high. And therefore because of its activation is required acid in environment, the sucralfate should not be used along with the proton pump inhibitor or H2 receptor antagonist. And another action of sucralfate, that the sucralfate is not absorbed systemically. So this is about the sucralfate. Regarding the colloidal bismuth is concerned, that we already discussed, the bismuth is antimicrobial, as well as this is also going to interact with the protein of the mucus, and therefore this is going to protect the ulcer. And this is also participating in the increased mucus secretion. So this is all about the cytoprotectant. Now we have to go through the last one, that the drug which kill the bacteria participating in the formation of the peptic ulcer, that is the Helicobacter pylori. So drug like amoxicillin, clarithromycin, metronidazole, tetracycline, bismuth subsalicylate are used to kill this bacteria. And usually we are not using these drug alone. I mean anti-helicobacter pylori, they are going to be used in combination, either triple combination or quadruple therapy. So in triple therapy, we are using proton pump inhibitor in combination with the metronidazole or amoxicillin and clarithromycin. So therefore, three drugs are used. So therefore, they are called triple therapy. So in quadruple therapy, we are using the four drugs, and these drugs are bismuth subsalicylate combination of, then metronidazole the second one, the third one is the tetracycline, and the last one is either H2 receptor antagonist or proton pump inhibitor. And this is all about the this class, and in next class we are going to discuss next chapter. That's all.